Wonderful. So my name is Silvia Nicolescu, previously Silvia Golița. I got married in April, and so the change. I'm a whole new person, much more responsible now that I'm married. I have to be a lot more responsible. And Bartosz was really nice and generous to invite me here to talk about ACT and cancer care, which is a subject I'm really passionate about, and that's been with me for the past almost 10 years now that I think about it. I kept saying 8, but time adds on, and it's time to change my discourse a bit. I'm also a representative of the Romanian chapter, and I'll just I'll just go ahead with my presentation. Okay, so let me introduce myself a bit. I am a psychotherapist and clinical psychologist by training. I live in Bucharest in Romania. I have a private practice here. I'm one of the founding members of the ACBS Romanian chapter, and I'm one of the people that is really putting a lot of energy into growing our ACBS community here in Romania. I'm really proud of that. We just had our very own national conference 2 weeks ago that went really, really well. And I'm also finishing up my PhD studies this year, hopefully, where I'm looking at ACT interventions for cancer patients in an online medium. Um, I was initially trained in CBT, but I'm also now certified in schema therapy, and I've been working for about 8 years with acceptance and commitment therapy, which is actually the most of my practice. Today we're going to be talking about ACT and cancer care, but I'm going to start you off with my personal experience with cancer care, working with cancer patients. Then we're going to talk a bit about what it actually is, the cancer experience, in case some people that see this lecture have never worked with a cancer patient, so they know kind of what they're getting themselves into. What does the literature on ACT say about cancer care? And then we're going to look at a few ways to actually put it in practice, some exercises, so that by the time I'll be done here, you'll at least have some rough ideas and some tools on how to work with this kind of this population. So I ended up working with cancer by not by mistake, but just random. When I started my master's degree, you had to do some volunteer work, and you also had to, my master's program asked of us that we do some clinical work in a hospital, and I just got assigned to the oncology ward. There are several hospitals where I was studying in the city where I was studying that offered this practice for students, and I just ended up there. I don't have any personal connection to this, but it just kind of happened, and I loved it so much, and it was so meaningful and so interesting for me. It just kind of stuck with me, and it stuck to till this day. But as a young CBT master's student, when I started going on the surgical ward, that's where I was assigned to, I was super ready. I had all my tools, I had all my protocols memorized. I was so ready to tackle anxiety and depression and insomnia and how to identify thoughts and dysfunctional thoughts and do restructuring and teach them how to breathe and teach them to do the whole ABC thing. And I was so ready to do that. And every time I would sit down with the patient to talk with them, people would they would actually ask for a psychologist to be assigned to them, and then myself or colleagues would go to their rooms. I was so ready to do the whole conceptualization and everything I had learned in school. So ready, so ready. And none of that ever happened, because all the conversations and all they really wanted to talk about was what they were going to do once they would get out of the hospital, who they missed, how glad they were that their family was visiting them. This was pre-COVID, when you could actually have people visit you in the hospital when you're sick, and how glad they were. Most people were older, so how glad they were that their kids were coming to visit them, even though some of the kids didn't live in the country anymore, but they flew in to visit them and be by their sides while they got surgery, and then when they got home to help them get back on their feet, how glad they were that their nephews were coming, or how sad they were that their family wasn't there for them. They were either away or in sort of conflicts in their family, and they didn't get along, and how hard it was for them to be alone, and how scared they were that everything that was happening to them, the cancer treatment, chemo, radiotherapy, the surgery, would prevent them from getting back to their dogs, to their gardens, to their houses. I learned a lot about gardening in that time of my life, because that's what people really wanted to talk about, what they missed, what they were longing for, what they were hoping that they wouldn't lose. Of course, also about the treatment. They were scared about it, but they were mostly talking about the impact on their lives and what they could miss, or they could miss out on, or what they couldn't do anymore. And people were very upset or scared if they thought that after the treatment they wouldn't be able to work anymore, or care for their kids, or care for their garden, or do sports. And I was not really listening for the first couple of months, to be quite honest. I was just waiting for an opening to insert an ABC, or an opening to insert a relaxation technique, or insert the things that I knew about. And that's what I did for a while. And it didn't really go that well, but people were nice. They saw that I was just starting up, and they were nice. I don't think they really considered me like an actual psychotherapist, more like a kid that's around, and sure, she listens sometimes. But a couple of months passed, and I started wondering why I really wasn't doing the kind of work that I hoped I would be doing. And I want to make myself really understood that it wasn't all good. People were really, some of them were really scared. Some of them were really depressed. Some of them were really depressed by the symptoms and the side effects of the treatment. So they were really burdened by it. But still, the things that I was prepared to do didn't really work. And thankfully, my master's program included a few courses on acceptance and commitment therapy. And about that time, we did those courses, and I started reading up on it, and it clicked so well about how these people, sure, they had difficult thoughts, feelings, sensations, memories, or projecting what could go wrong. And of course, they were afraid of death, and talking about death was a big part of it, and it is a big part of cancer care. But they weren't as focused on the actual difficult thoughts, feelings, and they were more focused on how that impacts their lives and the things they were going to lose, which is exactly acceptance and commitment therapy. And that's how I started getting into ACT. That's how I started learning and going to conferences and doing courses and trying to learn ACT and apply it to them. So thanks to cancer care, I got into ACT, and it has always been the best, in my opinion. Not necessarily the best, but the approach that is closest to the actual suffering that they go through, the approach that is closest to their actual experience, the things that happen to them, the aches, the pains, the fear, the perspective of dying, and having to learn to hold it lightly and go on with your life, because cancer care isn't something that you know how long it's going to take. No doctor in this world can correctly estimate how long you still have or how it's going to be for you. Cancer is very, very diverse. So this is basically what the rest of the presentation is going to be about. All right, I had this really nice slide that I forgot about, which basically relates to the fact that I saw people on the surgical ward in the hospital connecting so much to one another. And anyone who has worked in cancer care knows that people become friends during treatment. People are bonded by the treatment, and some of them really stay close friends throughout their lives, if they're lucky enough for their lives to continue. And it was very interesting to see that people, even though they were going through obviously the worst time of their lives, or mainly for most of them, the worst time of their life, they still had openness, and they still had the yearning to connect and to empathize with someone else, and to give compassion, to receive compassion, to see and be seen. And that was very weird. It makes sense when you say it, but I just thought that these people would be so overwhelmed by what was already happening to them that they wouldn't have the openness or the I don't know, willingness to discover someone else new in that particular time of their lives. But they do. And they do yearn connection, and it makes them feel stronger, and it makes them feel understood, because most of the times people back home, their families, don't really understand what they're going through. It's a specific experience, and it's normal, and no one wishes for their family to actually understand, because that would mean they had gone through it also. So now I'm going to talk a bit about what the actual cancer experience means. It's a roller coaster ride for most people. Not for most people, for everyone, it's a roller coaster ride. You have a few, hopefully a few really difficult moments. When you get your diagnosis, when you start treatment, when if the treatment doesn't work, you have to start another treatment. And basically the way that distress looks, if you were to plot it for any person who's dealing with their own cancer and their own cancer treatment, it looks like I think this has a name, something sinusoidal or something like that, which basically means that every time something new happens, maybe you get the diagnosis, or maybe you have to start chemo, or maybe you ended the first round of chemo and it didn't work, and now you have to start another round of chemo, or you have to go into surgery. Every time something new happens, their distress shoots up. Sorry, still be in the frame. It shoots up, and that's normal, because having cancer, it means a lot of different treatments and a lot of different stages, and it's not it's most of the time it doesn't mean only one, it doesn't entail only one type of treatment. It can mean different doctors, it could mean different sites where you get treatment, it could mean a whole different impact on your life. For example, if you get radiotherapy, you get that every day for a couple of weeks, and usually you can be admitted. But if you get chemotherapy, you get that once every 3 weeks. And that means that except the day when you get chemotherapy, on the rest of the days you're home, but you're feeling sick. Or you could have times where you're feeling sick right after chemo, and then you get better for the next 2.5 weeks, and then you get another round of chemo, and it's bad again, then it's good again. So basically, this is what their if we were to plot their distress or to plot the incidents of difficult thoughts and feelings and sensations, that's what it would look like. So when we're thinking about taking care of a cancer patient, this is what we need to know, that it's not just getting diagnosed and then they'll adjust to that and then they'll get better. Yeah, that will happen. And then they'll get surgery and they'll have to adjust to that and then get better. And then, and then, and then, and then, and then. And sometimes it could be over in, I don't know, 6 months, a year, and they could be in remission. But sometimes people battle cancer, as they say, for years, keeping it under control or keep getting treatment, different types of treatment, different surgeries, different chemotherapies, different hormonal treatments. It's very, very, very diverse. So this is what it looks like, and this is what we have to be prepared for and willing to face. And just because someone is doing fine in a section of their life, in a time of the year, that doesn't mean that's going to keep. Right. So a bit of background. This is some info I got off the internet this week. But cancer isn't all about dying. Sure, it accounts for 20% of the deaths, but overall, only 0.2 out of everyone in Europe dies in a certain year of cancer. The cancer experience also means having cancer and dealing with it, and not just you, but your whole family. Because when someone has an issue, that doesn't affect only their lives, but the lives of everyone around them, their kids, their partners, their parents, their grandkids, everyone. And the distress that they feel usually ripples through the family and ripples through everyone that's close to them. So if you think that it's that so many people die every year and so many people get diagnosed every year, that I think there was this, I couldn't find it, this info about 1 in every 6 families being, or 1 in every 4 families being affected by cancer every year, which is a lot if you think about it. And as I said, each new treatment stage means new adjustments. And I'm not talking about just the emotional adjustment, just adjusting to the diagnosis or adjusting to having to quit your job, or not being able to take care of your kids, or not being able to take care of yourself, not being able to cook for yourself or wash yourself or clothe yourself or hold yourself upright to take a walk. And some stages can be better and some stages can be easier to deal with, and some treatments can mean less disability and less relying on others, and so less practical adjustments within the family or within the whatever their support group is. Or other treatments can be more intense and more debilitating, and that means a lot more adjustment. The slide is so general because the cancer treatment being so diverse, it's hard to make a rule. So basically, my best advice to you is, when you have someone that has cancer, just ask a lot of questions about their treatment and what it means and how physically it makes them feel and how it's changed their lives and how their whole routine and family routine and life routine has changed, so you can get a better sense of the impact it actually has on these people's lives. Some people, for example, a part of cancer care could be to be in isolation. If you've gone through a bone marrow transplant, or if chemotherapy has made you so weak, you're very susceptible to viruses, they will put you in isolation. So that's going to be a very difficult experience, a very traumatic experience. And we need to know what our patients have, what our clients have been through, and what's lined up for them. And to understand this whole up and down roller coaster of a ride that they're going through, and that we need to be there for that. These are some specific issues that cancer patients deal with. So on top of what you already know or what you already have seen in your experience in working with people that have difficult thoughts, feelings, on top of what you know about people that have panic attacks, that have depression, that have insomnia, that have just about anything in the DSM. On top of all of that, these are specific to the cancer experience. As I just mentioned, this whole adjusting to new stages of their care, of their treatment plan, and it's especially harrowing when things don't go well. When you have a client that has a treatment plan set in place, and after that they hope that they'll be in remission and they'll be fine, and basically they'll move on up to being a cancer survivor. That's what they're called. And they don't. And their doctor comes in and says, well, you need to do another surgery, or we need to wait a bit more and do another surgery, or you need to go back into chemo, or you need to go back into radio, or you need to do this, or you need to do that. And those stages are particularly hard, and you will see a lot of flare-ups of everything that can be difficult and very painful in a human being. And that's mostly what you will see. I mean, as I mentioned earlier, there's no doctor in the world that can promise and keep his word when talking about a treatment plan. No one knows the way the body reacts. So, but people do hope, and of course, they hope they'll be healthy and well faster, sooner rather than later. Other common issues that you will always deal with is the side effects of treatment, and these could be very diverse. There are a lot of studies on protocols for nausea, for fatigue, for pain. You'll see them. But not all patients have them, but all patients do have some sort of, especially if they're doing chemo, radio, or hormonal treatment, they'll have some side effects out of the treatment, or even in surgery, just some residual pain. And you need to assess that and assess the impact that it has on their lives, and see where you can go from there. Sleeping difficulties, this is something you'll see with just about everyone, not just as a side effect of treatment, that could also be true, but also as anxiety's friends. It's roommate, or even just having their daily routine shattered, to use a dramatic expression. And sometimes it could be really hard to find a new routine while going through different types of treatments. Something that's also very, very important and needs to be discussed are relationships, and how you adjust, how you tell the news to your family, how you tell the news to your kids. Something that comes up often is breaking the news to elderly parents that, of course, usually worry a lot. So also, always when someone is diagnosed with cancer, they start worrying not just about themselves, but about their family, and how it's going to impact them, and how it's going to worry them, and how it's going to uproot their lives also. And that really needs to be discussed, and it's a good idea to discuss it. But also, once you get past that stage, again, one of those hills, There's a lot of discussing and working on having readjusting the relationship that you have to the ones that are close to you, readjusting it according to your, for example, your energy level. If we're dealing with fatigue or nausea, if we're dealing with these type of side effects, people will have less energy. And how can you still be a good mom, how you can still be a good dad, how you can still be a good grandfather or whatever, a dog owner, parent, while you're dealing with these side effects, and this needs to be addressed. A lot of issues come out of body image concerns, a lot, especially for women. It's very difficult, especially for women that either get mastectomy or they for some reason need to take out their reproductive organs. And of course, it depends on the age that this happens. But you will see a lot of women that feel that they're not a woman anymore, that feel they're not feminine anymore, that feel they're not whole anymore. And this is a side effect that will last. But also you have the side effects regarding the body image concerns of the side effects of the treatment. People lose weight or gain weight. They can lose their hair. They could change the color of their skin. They could change the texture of their skin, or they could just look sickly because they are sick. And this is also something that shows up a lot, and people have a really hard time talking about it. People will feel a lot more at ease talking about their family or the things that are important to them than themselves and their bodies. And I'll discuss this later on, that sometimes people get into this kind of conflict with their body because the body is the one that's sick and the one that's ruining their lives, and these need to be addressed. Also, a common issue is sexuality. Just because people have cancer doesn't mean they don't need to have sex. Just because they have cancer doesn't mean they don't need to feel sexy or wanted or beautiful. Doesn't matter if you're a man or if you're a woman, you still need to feel sexy. It doesn't matter if you're 20, 40, 60, 80. I've seen it, and it's really nice. And also this is something that shows up, and people stop having sex or stop having hugs, and that's something that needs to be addressed. And of course, last but not least, death and dying. It doesn't matter what stage the person is, there's always the prospect of death. It doesn't matter if their stage is like stage 1, and they're just going in for surgery. The prospect of death, dying, what their lives meant so far, what they would be missing out if their lives were to end earlier. This is always something that you need to feel comfortable talking about, not just be prepared, but actually feel comfortable, because people will have a hard time naming it and discussing it directly. They'll say what they missed or what they would like, but they kind of hate saying it. And that's always a good subject for diffusion. Any questions so far about being a cancer patient?
None currently, I think.
Okay, good. Okay, I'm going to take you through what the literature says a bit about ACT, acceptance agreement therapy, and cancer care. This is a slide off of, the site. I'm sure you know the site. There is currently a SIG, special interest group, that has just been set up for cancer care. And so far, the ACBS community has indexed 28 studies that somehow investigate using ACT or ACT protocols or ACT-based interventions for various types of oncology issues. In this list, you'll see smaller studies, larger studies, pilot studies, case studies, a few randomized controlled trials. I'm sure that people have been using ACT for cancer care for a lot of years, but the literature is just starting for the past few 5-10 years. The literature has started to show up. We all know it's kind of difficult to do a study, and it's a lot easier to just implement it in your own practice. A lot harder to set up a bigger study, but the evidence is there, and when you do need it for it to be there. And there have been some studies since the early noughts, something like that, that said basically what I also found in my own experience, that the intervention model is more suited, or is potentially more suited to the actual experience and to the cancer adjustment. And this isn't something that would just us, the people that work in cancer, this year, which is really nice. This year, I think a month or two ago, nice, has come out and said that ACT is a proven type of intervention for chronic pain, and is okay to use it, and it's not okay for cancer patients that are dealing with pain. Most of the studies that you'll see they use acceptance and commitment therapy for cancer patients, but specifically aiming at a type of symptom. So they're either targeting insomnia. There are a lot of studies on insomnia, or they're targeting pain, or they're targeting fatigue, or they're targeting nausea. So most of the studies have been done targeting a specific outcome and following that one, targeting it with a specific content of the intervention, and following that. So this is a slide. This one is in the next one. It's not systematic review or anything like that. It's just a few examples of a few studies. There are a lot more studies that say the same thing, that distress and the impact symptoms have on patients, and it's the mechanism or the change process that needs to be fully changed for these patients. And as such, ACT is useful in improving quality of life, reducing distress, reducing anxiety, reducing depression, reducing physical pain, or at least the way pain is perceived, and its impact on patients' lives. And there have been a few studies on the fear of recurrence. That's also something specific to the cancer experience. Once people are considered to be survivors and they no longer need treatment, they just go in for regular checkups once a year or twice a year, then there's still this fear of recurrence, and sometimes cancer does come back. But basically what we see in these studies is that whatever comes along the way, whatever pain or other side effects you have during treatment, or whatever symptoms you have once you are a survivor, such as fear of recurrence, or even if we're talking about the kind of symptoms or difficult experiences that you see across the board, and quality of life, quality of sleep, when we look at, and whatever the patient is dealing, acceptance and commitment therapy does have a solution for that, there is a protocol. Someone has tried it out and has been proven to be efficient, smaller or lesser effects, but it has been proven to be efficient. And that is interesting, because basically it shows that it targets the underlying mechanism, psychological flexibility. And basically it means that we don't really need to worry that much about each specific stage, but just we have to know that as long as you target that psychological flexibility, you can help the patient deal better with whichever stage they're into. And even if you finish treatment with them, they'll still have the tools and the skills to help them through the next bump and through the next bump and through the next bump. You don't have to be there for the whole time of their cancer journey, which can be a long time. And there's even a post-surgical pain and anxiety that use a single session, which is always, I know there are a lot of ACT studies that use only one in one session, and it's always mind-boggling to see that it works and it does have some impact. And these are two more studies that kind of, these quotes explain more why ACT is useful, and how ACT basically frames everything that a cancer patient is going through. That most people, like regular clients, they'll come in and say, well, I don't want to feel any more pain, or I don't want to feel afraid, or I want to stop thinking about the surgery I'm going to have in 2 months, or I want to stop thinking about the scan I'm going to have in 2 or 3 months. That's going to tell me if the chemo is working and I'll be healthy, or it's going to tell me that if things are getting worse. And people do come in with these things and say, well, when I get rid of these, then I can get my life back. I can get back to the things that really matter to me. And of course they know, and that's where ACT is really useful. It's really easy, and especially for cancer patients, kind of easy to explain creative hopelessness, because they know that as long as they're going through this cancer journey, these things aren't going away. And not only that, these things are not going away, but there's a potential for more shit to show up, more bad tests, or more tumors, or more treatment. And they know that, and this type of population is a bit more prepared to embrace creative hopelessness and embrace the whole skill set that ACT is offering, because they kind of already know that going in. No one really thinks that they can stop worrying like this. No one thinks that it's absurd to be worried about these things. No one thinks it's absurd to be worried about death, basically. And ACT really comes in and frames this really lovely and really elegantly. And the feedback that I've gotten a lot of times out of patients is that ACT really makes sense, and it makes sense with their experience, and it makes sense with what they're feeling, and it opposes basically the type of good-natured advice that they would get. Oh, stop worrying, be optimistic, just think of nice things, don't be afraid of surgery, you have to stay optimistic and have good thoughts, and if you have good thoughts, you'll be healthy. If you have bad thoughts, you'll die. People do get that type of advice. And the way ACT frames valued living in the midst of suffering and pain, both emotional and physical, really hits the spot and really makes sense to a lot of people, and they're so willing to try it out and to do the work and to actually practice the exercises and the skills, and find that bit of joy and significance in their lives, no matter how fraught it is with treatment or whatever it is. everyone knows the Hexaflex. I'm not sure what I put it here. Oh, right. So let's get more specific. This is the Hexaflex, and you have all the 6 processes. When someone comes in, what do you do? When someone comes in, how do you start? When someone comes in, what do you start with? Listening to most people's discourse, you'll, if you're open and actually listen, not like I was in the beginning, you'll hear values. You'll hear basically in the first 10 or 15 minutes, you'll hear a lot of things that are very important to them, values, valued domains and people and activities. Cancer really makes you think about what's important in life, and cancer really helps you prioritize things. So one of the best ways to start working with someone that has cancer is to start talking about values and start identifying them and start highlighting them, because people do say these things, but they don't really realize, and most people will, as you know, focus more on outcomes rather than on values. And when you're physically limited or whatever else limited, it's a lot harder to do to set your mind on doing something and actually get it done if it's more complicated. So we really need to start working on values and separating them from goals and moving into committed action, into actions that are doable for every stage of the cancer treatment and every level of energy people have. So you always can and should start with values, even though people will want to talk about, or they'll mention a lot of, I don't know, other thoughts or feelings, and you might be tempted to go into diffusion or to go into present moment or to go basically any other one, because you'll hear them saying things that make you, oh, well, that's a thought, and I can see that they get really hooked by it, or they're really fused by that, and it really shows up again and again. My recommendation is to always start with values and to always ground the person in what is important in their life. Who is important in your life? Also talking about their lives before getting cancer, before their diagnosis, who was important, what were you doing, what was meaningful before, because a lot of people will give up stuff because they feel they can no longer do them at the same level they used to. Sports or traveling or even seeing people and socializing and attending gatherings as much as you can right now. And it's really important to tease values out and see what's important and what makes their hearts skip a beat. And these classical questions, if everything with you was better, or if the classic magic wand question, if you were in remission, if you weren't feeling sick anymore, what would you do more of? What would you do less of? What would you say? How would you be? That whole part of teasing out, and also asking what you miss most. What do you miss when you're in the hospital? What you miss in the days when you're feeling sick or too sick to do things? What do you miss the most? And that's where I mean that cancer has a way of churning things and helping you figure out what's important. And this is really very useful work that sticks with people for many, many years to come. And I've had patients that managed to overcome cancer and become survivors and use the work that they did on themselves while they were battling cancer to improve their lives. And even if not, it even if it's a bad diagnosis, it's a bad, you know, the doctors aren't really optimistic. It's still very useful to start talking about values and what you want your life to be about, and what kind of role model do you want to be. When I wrote this question about role model or presence do you want to be, I was thinking about I had a patient a couple of years back, about 2 or 3. She was um, she was Romanian. She was living in the States, and she was a very, very talented doctor. Um, I I don't remember the kind of doctor she was. Maybe she was an oncologist. I think it was something related to her cancer. And she was, from a very early age, she was very driven and super alcoholic, and she left Romania on a scholarship and did med school in the States and had a lot of fellowships. I'm not really sure what those are, but when she told me about it, it seemed like something really, really important. So she was a very good doctor, but she had focused her entire life on being a doctor and working very hard. And she worked very long hours, and she was very dedicated, and she helped a lot of people. And then she also had a kid. She had a little girl, and then she got sick. And she got this tumor in her brain. I don't remember what it's called. And she really fought for a couple of years, actually. For 2 or 3, she kept going through chemotherapy and through surgeries and through chemotherapy and through surgeries. And I met her closer to her end. She was recommended to me by someone who knew me. And she was very depressed. She was mainly depressed because she felt that she had wasted her life. That looking back, she had worked a lot and she had achieved a lot in that area, and she was very respected, and she had a good position. But she was joking about the fact that it only that only brings comfort to her because she had very good medical insurance in the States. That was a big deal. And that was the only reason why she was proud of her professional achievements. But she was feeling very anxious that her little daughter, I think her daughter was about 4 or 5, something like that. So about 3 when she was diagnosed, that her daughter was not going to know her. She was a single mom also. And what would her daughter do? Who would take care of her? She had a sister, and her husband were also living in the States, and that was an option. And how would her kids' life be, and how much she felt that she had messed up. She felt that working so hard had been a not necessarily the reason she got sick, but the reason she didn't get diagnosed earlier. So what she did manage to do in the last year of her life was to reach out and get back in contact with the kid's father, and she managed to have him take care of the kid, and she managed to establish a really nice relationship with the man. They had been together for a couple of years, but then they've broken up before she gave birth, and she was fine with that. Even she didn't love him anymore, he didn't love her. But in the last year, she managed to mend that relationship, and she was alive long enough to see that guy fall in love with the little girl, and him actually become a father, and see that bond between the two of them emerge. And basically that's what she did for the last year of her life, focus on what she wants to leave behind and what kind of, even if her daughter would probably not have many memories of her, and her daughter would probably not remember much of her because she was so young, what kind of context or life would she want to build for her daughter, and what kind of place she would want to leave her, and not just physically, but what kind of family she would want to take care of her further. And she really put a lot of energy in that, and she would fly cross country because he was living in a city and they were living in another city. And I remember seeing her after she had moved her daughter, and her daughter was fine and they were getting along, and he was a dad now, and the kid was feeling at home. My client had managed to create a home for that kid to leave her in. And I could see that she was a lot more, she was about 40, so she wasn't happy about dying. Because was when you're 40, but she was a lot more at ease. And she was a lot more at ease that she had done everything that she could, fighting her own cancer, but also taking care of her child. And if this is the extent of it, then that's fine with her. So that is the kind of work you can you can do when you're talking about values. And with her, we basically, this was something that we talked about every session, and always this was the thing that we kept going back. What kind of person do you want to be? What kind of mom do you want to be? What kind of sister do you still want to be? What do you want to leave behind? You are leaving. There's no question in that. It could be this month or it could be next year, but you are leaving soon. So let's talk about that. Let's look that in the eye and see what you really want to leave behind. And of course, it's really difficult to do that at first, and people are scared. But that is, in the long run, that is the healthiest way to help them in this cancer journey. And as like a practical exercise, you could always focus on top 3 relationships in their lives to basically save time, to always focus on top 3. Who are the most important 3 people in your lives and in your life, and what are the top 3 valued activities in your life? Never mind what you think you ought to like or what your husband says you ought to do. Close your eyes and just give me top 3. And that could be difficult for some people because they'll get, and it's an exercise and also in cutting through the noise and realizing what's most important to you and what's just been, I don't know, thrown on you is the right way to put it, but just things that maybe you have spent your time on and weren't that important to you. If I'm thinking back on this client that I just told you about, she realized that she was doing a lot of she was doing research, and she was also teaching alongside being a doctor. And she realized that the research that she was doing wasn't really that important. I mean, it was more for her own ego. And she focused more on the teaching part because she really had mad skills as a doctor. And she really had a nice way with patients. And she realized that this is a skill that's really worth, that is very important to her, and that she spent a lot of time cultivating it, and that she would feel so much better if she knew that she had taught students or residents or whatever those were, the things that she knew about patients and how to talk to them and how to manage them and how to the human social component, and that she would feel a lot better if she knew that she gave that and passed that on. And she did. And she did. And she stopped doing research because she wasn't, she probably wouldn't have been around to see some of her studies published, because it takes years. So cut your losses. And once going back to the general idea of working with cancer patients, once you've established and you have a pretty clear image of what is important to them, who is important to them, what kind of activities do they value, and what kind of people and activities are really meaningful to them, it's when you step into the whole taking action part. And this is an exercise that's called salt and pepper, hence the image, which can mean, maybe some of you know, which can mean asking for and identifying the smallest thing that you can do that is related to that person and to the value that you want to bring into that relationship or to that activity that you can do tonight, that you could do right now, that you could do tomorrow morning. Not when you'll get better, not when you'll finish your chemo and have more energy, not when you're in remission, not next week, not when it stops raining, not now, today, this evening, tomorrow. What is the teeniest, smallest, teeny-weeniest action that you can take? And doing this with them and giving this as a homework helps them. The idea is that you don't have to feel healthy or to feel yourself. To do things that are valuable and meaningful to you. And even though maybe giving a hug is not the same as having sex, or giving a hug is not the same with, I don't know, helping your kid with their homework, because that's something you can't do right now. It's not the same thing. It's still in the same direction. And that is what's most important, to keep moving in the same direction, in a valued living direction, that is. And it kind of teaches them, out of this exercise, you could also start to tease out the thoughts. It's not good enough, it's not enough, you could do more, you should do more, not a good mom, whatever. You keep that for that part of the work. But also it helps them start moving a bit more and doing a bit more, just even the smallest things, like calling someone, or I don't know, taking a walk, even if they used to be ultra marathoners before. It really, and it builds up on that flexibility to do the smallest thing, not like a grain of salt or a grain of pepper. But the idea with salt and pepper is that it puts salt and pepper on your life, and it gives it flavor. It doesn't matter if it's a teeny bit or a lot, it still gives flavor. And as I said, while we're doing this work, figuring out values and value domains and important relationships, and trying to set a course to some actual actions, you'll notice, and they'll notice, and you'll notice what shows up, what kind of thoughts, what kind of feelings show up that paralyzes them or keeps them from doing more of what's important. And these are just a couple of examples of I'm not good enough, I don't have time, I don't have money, it's hard to do it by myself, or I'm too tired, or too old, or too skinny, or too fat, or too sick, or too whatever. It's useful to also investigate how long have they been telling themselves the story, because it might be related to the cancer experience or it might be not. the whole I'm not good enough story usually isn't brought on by cancer. It's usually something that has been with them for a very long time and lurking in the background. And having being impaired, physically impaired, really flares it up. And this is also a good material for a session to talk about the story that you're not good enough because you're sick or you're too tired or you have to go into in for treatment and you don't have time to take care of your kids or your company or your dog or your family, whatever. And this time it's about cancer, but has it ever been about anything else in your life? Is there something that you've heard your mind say before in different times of your life and different difficult times of your life? This is what your mind does when you're sick and you're frail and you're battling cancer. This is what it does. It just kicks you and it's useful to do any kind of diffusion work around this. Um, Anything that you're comfortable with, anything you like doing, and anything you find in a protocol, from notice, naming the story, singing it out, whatever it is. And this is kind of the slide that I did is a sort of a map about things, processes, thoughts, feelings, emotions that usually show up when we start talking about values. Even though you hear it in their discourse, that doesn't mean it's going to be simple. And even when you start talking about them, if it moves smoothly, then they don't. Then that means they're already very flexible and they don't need you that much. But what would happen? What happens usually? The kind of walls that you would hit are these in terms of the machine mode. And a lot of the times it's actually necessary. I don't know what's it like in other countries, but here patients rarely have a navigator. So once you get your first, I don't know, scan or something, and something is not right, and maybe the person that did whatever test they did sees that something is not right, then you have to find for yourself another doctor that could do a better assessment, and then with that assessment, you have to find your own oncologist. And after you find your own oncologist, you might have to find, according to his or her recommendations, you would have to find your own surgeon, or you would have to find your own radiologist, or you would have to find your own I think that's about it. But if you need what's it called, after surgery you need to do some recovery, some physical recovery, then you have to find your own doctor for that. Or if you need to do some if you have to have a nutritionist, and again you have to find that one for yourself. And it's kind of daunting when you get your first test and it says that it's not good and you need to further investigate. It's kind of daunting to have to find all of these doctors and have to find the best center for you and the best time to start doing them and the money to do it, because again, this depends country by country if these things are covered by your insurance or not. And at least in the beginning, and then in certain other stages when maybe things don't go well or you need to go into another stage, people do need this problem solving machine type of thinking, because these are real issues that they need to take care of. Some of them will have family or friends that can help them, but most of them have to deal with these things themselves, or at least with their partner. So this is something they do get into, solving problems, and then they have a hard time getting off of that train. And I actually have a client, a recent client, and she had some tumors in her ovaries, and she had to take them out, and then she had to find an oncologist. I started doing chemo, and she did this, and she she and she had this Excel sheet with information and rating and criteria. It was insane. She showed it to me. It was absolutely insane. A bit much, obviously. But then she finally came to a decision and started doing chemo. She picked an oncologist and picked a center and started doing chemo, but her mind was still doing that. She couldn't get off this problem solving machine train. And she noticed that even though she had found the solution she was looking for, it was hard for her mind to settle and just not keep moving, keep looking for I don't know, creams or vitamins or anything like that. And they will do that. Or I mentioned the regret generator, when people really have had lives that weren't really, they didn't do the things that mattered to them, and they she has a lot of regrets about not going sooner to see a gynecologist to get a checkup, because she felt that something was wrong. And maybe if she did, she wouldn't have needed the extreme surgery that she got, and maybe she wouldn't have needed the chemotherapy. She's my age. She's 33 or 34, which is really young for this kind of issues. So when you start talking about what's important in their life, this is one of the things you can see. And of course, working on mindfulness and mindfulness-based skills is something that's really helpful. What you will also see in terms of self as context is these, and this is the part that I really love, is this identifying with the labels that I am sick, I can't do anything. This becomes the story that people tell themselves, is the story that other people tell them, that the doctors tell them, the nurses tell them, the family around them tells them, their employer tells them, everyone. You're sick, you're a patient, you're dying, you can't do anything, you're sick, you're a patient, you may be dying, you have cancer, you may be dying, and so on and so forth. And it really infiltrates their pores and their every cell. And they start thinking of themselves only as that, and seeing themselves only as that, and start losing any kind of sense. Some can lose any kind of sense of them as a person that has cancer right now, not cancer in themselves. We talked. Got it. Yeah, you could restart recording. So I hope that the Wi-Fi um is my friend for. Right. Thanks. So that part with cancer as the self story that people will tell themselves is obviously the self as context of self as content process, and it's very, you'll hear it, and you'll hear it quite clearly from the beginning, and you'll hear it quite often. There are very few people that don't do that, and even if they don't start off as that, sort of the system and the way most doctors, or at least in Romania, most doctors and nurses talk to their patients will get them there. They're not really self as contexty, really specialists. And in terms of diffusion, you will see these questions a lot. You will see these thoughts that constantly hook people and constantly fuse with people. Why me? Why now? What have I done wrong? Have I been sinful? Have I not been a good person so far? Why has God punished me? Why is this happening? Why is my body punishing me? Will I be ever well again? That's a real a big one. Is the treatment working? Again, this is something that people worry constantly all the time. Am I doing this right? Because people will get a lot of advice from everyone about what they should be doing, what they should be eating, what they shouldn't be eating, what they should be doing, exercising, drinking tea, different types of herbal teas, taking supplements, not taking supplements, working, not working, blah, 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 blah. And a lot of people will worry, am I doing this right? Am I being a good patient? Am I really taking care of myself? Is this going to help me? And of course, the thought behind the thought that's always in the background is about death. Will it happen? Will I die? Will I die soon? What will it be like? What will I feel? What, the whole range. And this is something that you really need to assess, because it depends on people that are religious are going to have one set of thoughts, and maybe they could feel more either at ease or either in danger of being punished if they feel they've been sinful. Whereas people that aren't as religious, they could have a whole different experience, and you really need to tease it out and evaluate it and see what kind of thoughts show up and what kind of thoughts fuse with them, and what kind of thoughts keep them from doing things that are more meaningful to them in the present moment. Okay, and in terms of acceptance, you will see the whole range of human suffering that they need to find some place to to put. You'll see fear, you'll see loss, you'll see a lot of hopelessness a lot of times, a lot of physical sensations, and then, as I mentioned, some big body issues. This slide is more about what kind of exercises you can do. Mindfulness has a lot of studies backing it up as a really good intervention, and that facilitates act and facilitates better outcomes for them in terms of pain. So all this whole section of physical symptoms and sleep issues. It's really recommended. And these are a few recommendations of exercises that you can do, and especially that you can modify and adapt to their experience and to the cancer experience. What I always do in terms of diffusion is kind of circle around the C word, the cancer word, and see how easy it is for them to use it, and how easy it is for them to use it for themselves or to communicate it. And this is something that you also need to pay much attention to, that you don't avoid words. People will want to, not want to, but if you listen to their language, they'll sometimes avoid cancer or death or mastectomy or whatever the surgery is called. And you would want to address that. And you, for once, you would want not to also do that. And also talk to them about, when you say the word, what kind of feelings do they show up, what kind of thoughts, what kind of emotions, and work a bit around that. You could actually get to the point of doing the milk exercise with cancer. Not from the first session maybe, but you can do that, and it's just a word, just 5 letters, one after the other. It's not a big deal, but you have to tease out everything it means to them, all the image that pop up in their heads, all their sensations or their thoughts, everything. Also, a thing that I really like to do is focus a lot on their body and how they relate to it. And a lot of people have a really hard time. It depends on the type of cancer and the type of surgery they've had, but a lot of people have a hard time to look at their scars, to look at the place where they have had their surgery, and to look at it with kindness and with understanding and with maybe even with love. So especially for women that have had mastectomies or other surgeries like that, partial or total. An exercise that I really love and I really insist on doing is this applying moisturizer on yourself, on your skin. And I always ask if they do that, and if they do that, how do they do it? If they do it quickly, or do they do it tenderly, or they do it caringly, or when they take a shower, if they wash themselves tenderly, or if they just soak themselves up quickly and then get on with it. Or of course, even if how comfortable they are looking at themselves in the mirror, and not just the parts of their body that have been through surgery, but as I said, through the whole treatment, your appearance changes and you may look more sickly. And hair can fall out, even though it's not as common anymore. But how do you look yourself in the mirror? And if you still apply what you used to do, even with men, if they still shave themselves regularly, there are a lot of men that really enjoy the whole process of, especially older men, and they tend to get cancer, that they really enjoy the whole process of shaving themselves in the morning and having like nice foam and like nice smelling foam, if they still do that, or if they just brush their teeth and that's it. So this whole self-care thing, physical self-care, because there will be people that go to all of their doctor's appointments and eat better and take their vitamins, but they have a difficult relationship with their body that is failing them, the body that has betrayed them by getting cancer or by getting cancer again. And that is a area that's really lovely to work on, and it's really useful to work on. And especially the hand-on-heart exercise that I'm guessing that most of you know, modify to hand on whatever your cancer is, on your stomach, on your head, on your skin, whatever it is. And it can be a hard exercise to do, but it's worth building up to that, and it's worth even finding ways to introduce it more lightly, just imagining your hand on that area, or having a blanket or something fuzzy on that area, and then building up to your actual hand on your actual skin. And this whole idea of working on on your body, and accepting it really opens the door and facilitates really nicely the observer self stance, that there's myself and my body, and the way that I treat my body is my decision. But even that phrase in itself differentiates the two entities. And I would do some sort of observer self kind of exercise, maybe the chessboard metaphor, or maybe actually the meditation, the longer one, where you close your eyes and notice your thoughts, your feelings, your memories, your roles, your body, your everything, and you work on teasing that observer self perspective. And also something that's really lovely to do is to get into the habit of writing letters towards your body. Writing letters that can really express whatever it is that you're feeling: sorrow, anger, care, love, compassion. And they could build up, and you could negotiate letters around a certain subject or a certain emotion or a certain thought. And it's a nice way for people to express their anger, their sorrow, their loss, especially to organs that they may no longer have. And it's a really nice way to make more evident this whole distinction between myself, my true self, and this thing that's happening to me that's called cancer. And you could even do chair work with you in a chair and your cancer in the other chair, and could lead to very different, very interesting avenues. I think I'm almost to, yeah, this is the last one. I've told you all of this about working with cancer patients, but I've started with myself, and I want to end with you guys. Working with cancer patients is difficult, or it is and it isn't. It's definitely something that will trigger things inside of you that other patients won't trigger. But I also see it as an opportunity for us to think about death and think about what's really important to us, and how you want to live your life, and how you want to treat the people around you as if you could get cancer tomorrow. That has been my experience, to be quite honest, and I'm really grateful for that. But I've seen along the years a lot of my colleagues really struggling with this, and it's okay to have a lot more resistance towards the idea of death. It's normal to resist the idea of death. We're all human. Don't want to die. That's the whole thing with us humans. And it could be really nice, and having a cancer client, someone having as a client, someone that's oncology patient, can be a really nice way for you to notice things about yourself, and notice your own avoidance and your own fears and your own challenges and your own difficulties, and hold them lightly and be compassionate towards yourself, because again, there is no more painful subject than death, dying, loss, hurting others, being lost for others. And it could be really meaningful work for both you and the patient, as long as you are mindful of these aspects of your own self. Because otherwise, as it's true for other kinds of therapies, if you have to be very, very mindful of what you're modeling. If you yourself are in a place of emotional avoidance of certain areas, of certain topics, of certain things, then that's what you model towards them. And especially towards cancer patients, people that model fear and rejection and shame and fear, it's not the best as you can can imagine. But it's normal if it shows up inside of you. We're still humans. We're still afraid of dying. We're still afraid of death. We're still afraid of illness. We're still afraid of pain, and it's normal. Just because I'm a therapist and I've read protocols or I've watched a webinar doesn't mean, and I have, like a list of issues and techniques and where people can get hooked or what processes go which way and what to do with them. Just because I have this list in my head, and hopefully you have it now more clearly, doesn't mean that it's easy work. It's a whole different experience of knowing and actually being able to model it, and even modeling your own mindfulness, of own awareness, and holding them of own avoidance and holding it lightly is something that they'll see and will appreciate. They don't expect us to be zen and not be afraid of death and not be, be completely. And doing that basically with them witnessing us is a wonderful way to teach them and model it through us. So basically, don't be afraid of that. Don't think that you have to be okay with your own death to work with someone like this. And it's okay to be open and honest about how scared you are or how scared you would be if you were them, and so on and so forth. Just be mindful and hold everything lightly. Okay. Resources. There are a lot of nice studies, as I've shown you on contextualscience.com. There's a cancer SIG recently set up, and there's also the International Psycho-Oncology Society that also has some measurement tools. They have a annual conference, and they have a lot of, they don't base themselves on any paradigms. They're just psychosocial cancer care services as a whole, and they're a nice organization. It's a good idea to keep an eye on what they're doing. Thank you.
All right. Any questions? I know that Jędrzej has some. Is it?
Yeah. Can I go ahead? All right. Thanks so much. That was beautiful and really, really helpful. Totally new perspective for me. And I especially appreciate the part of like perspective switch that happened in my mind when you were talking about the fact that actually certain things are kind of more kind of closer to the surface in cancer patients, and we can, as therapists, we can use it to our advantage. So you mentioned helplessness in this context, and you also mentioned values in this context. This is very interesting way of thinking about it and putting it. I have two questions. One is related to values. This is you mentioned it, and you said some things about it in your talk. But so I'm just wondering. It feels. I mean, values are tricky, right? So values are tricky to distinguish from other things that seem or sound like values, but are actually, controlled by some social aversive stimuli and stuff like that. And typically, when we think about, at least, what my impression of like reading the protocols or hearing about the how the therapy went, it's not like values rarely appear at the very beginning. Like sometimes a lot of things have to be done before the client is really able to kind of connect with the valued things, freely in this, fully and valued manner. And you mentioned that that there is this dichotomy. So on one hand, people, kind of the important things in the lives of the oncological patients just resurfaced because of the fact that they are oncological patients, and they start thinking about it. and then they start talking about these things. But then I'm wondering whether you find it difficult, and how often, and whether this is a real danger that, you know, they just, the topics just resurfaced and they might be guided towards the things that sound like values, but they are really things that they, you know, they've been trained to you know, to think are important. So, so yeah. And I have the other question that maybe I answer it later, or I can keep going.
Yeah. Let me answer this one. So, yeah, that could happen also, but what they say is a value actually is just something that they feel they should be doing or should be behaving in a certain way. But the interesting thing is, most people, if they come to see a therapist, they'll start seeing someone usually after they've started treatment. So when you get your diagnosis, that is not the stage where people are really interested in getting in therapy. They're interested in finding a doctor, and they're interested in finding treatment and finding a center. So usually, usually a couple of weeks, maybe months pass between the actual diagnosis and the time they will start seeing me. And that has given them a lot of time to do some thinking. And, you know, yeah, maybe and I've seen people do there because they're really accept, you know, helping them chill a bit and focus on what's important to do then. But usually you will see people, or at least in my experience, because I work in a private practice. Maybe if you're working on a ward all the time, but when you see people in your private practice, they're usually a lot more, I don't know how to call it, settled. And they've had some conversations with themselves, and it's been a couple of months, and they've had time to think a bit about, and they're more closer to the stage where they actually understand what's more important to them, and they've started doing most of, or at least I think most of them have already started this work of differentiating between what is really important to them and what they thought it was important to them, and they had been doing for a long time. And you'll hear that in their discourse if you see people after a couple of months of already being in treatment and already being cancer patients. If you see them in the beginning, no, you're right. It's all going to be. But if you see people that have been living with cancer for a while and have been actually thinking about these things, even in, you know, at night when they can't sleep. And then that's really interesting to see that people get to that place. And yeah, they need help because their mind will try to overcome that, and you're not good enough, or you shouldn't be thinking about these things. You should be focusing on you're sick or whatever, anxiety, or going for a scan tomorrow. And they do need help to get these things out of the way so they could see them more clearly and then move into that whole action side, because that's the trickier part, because they could see clearly or clearlier what's important to them, but moving into action and doing something about it and not putting it off until I get better, that's the hard part, or at least in my perspective.
Yeah, great. That really helps. Thanks. The second question concerns do you think that there are some good functions or benefits that might come from self-identification as a cancer patient? So I'm thinking, like, you know, it might be a part of this bigger narrative. You're sick, you cannot do anything and stuff like that, and it might trigger, you know, just this, I'm not able to do anything, and I'm categorized by anyone in my and everyone in my environment as a cancer patient. But I also can at least imagine people who might I don't know, like feel more connected with the group of other cancer patients, and I can. So I'm just curious about your experiences about the possible positive aspects of self-identity.
Yeah, it could go. Like you said, it could be some helpful aspects if you've always identified yourself as a professional, whatever job you have, and that was your story, and now you get hit with this story, it might help you have the idea that they're all stories and maybe there's more than that. I felt so strongly about being a marketing person, and now I'm no longer that, but I'm still breathing. So who am I? So I've let go of that narrative. I'm now a cancer patient, but I was so attached to that one. And how could it be that I was so attached to that one and I no longer have it, and I'm still standing, I'm still here, and I'm maybe, and yeah, of course, the bonding between patients and their support groups, having the same experience, having the same or similar experiences, that also can be a benefit. But I see it as a benefit in actually moving you towards office context. You thought you were something, you're not, now you're something else. Are you really?